This PowerPoint will cover the care of patients with peripheral vascular disease, specifically arterial disease. Let's start with some definitions here because it's important that you understand the difference between arteriosclerosis and atherosclerosis. Both conditions begin early in life and progress without symptoms through adult life, which is when the symptoms begin. Arteriosclerosis is a thickening of the arterial wall. They lose elasticity and they calcify and become hard. It's part of the aging process. The intimal lining of the artery loses elasticity and weakens due to the high pressure of your blood pressure over time. Atherosclerosis is from inflammation, and it causes the development of collagen and fibrous tissue. It's like a scar. And it happens because of the formation of plaque within the arterial wall. This is what causes coronary artery disease, but it also happens in other arteries besides your coronary arteries. And we talk about this, the pathophysiology of this, quite a bit in the lecture of coronary artery disease, but I'll go over it just real quickly here. So you get an injury to your endothelium, and this causes inflammation and the growth of scar tissue. And what happens is you get a fatty streak, and this builds up. The plaque builds up on top of the smooth muscle, and you get fibrous proteins, cholesterol. This fibrous cap develops, and it can calcify and harden. And this, it's like a little bump or a hill or whatever inside and it's very irregular. And if you recall, the inside of your arteries, that intimal lining is very slick and smooth because the blood needs to flow by without cells and platelets catching. And so when you get this this cap, it causes turbulence and stenosis. It closes up or makes the opening of the vessel smaller. This cap can rupture and form a clot, and that clot can block your coronary artery. It can block your carotid artery. It can block any artery down in your leg. And so a partial or a total occlusion of blood flow happens behind this clot or this stenosis, and this is what causes the symptoms in peripheral arterial disease. This risk factor list should sound pretty familiar by now. You have the non-modifiable risk factors of age, ethnicity, gender, and genetics, and then the modifiable risk factors of diabetes, hypertension, elevated serum cholesterol, alcohol use, obesity, sedentary lifestyle, stress, and of course tobacco use. And tobacco use can also include passive smoke as well. Peripheral vascular disease in general can either be venous or arterial in origin. These have very different symptoms and very different treatment. And so assessment becomes very important to differentiate between the two. For instance, here is an illustration of what the ulcers look like. So on your left is a very typical arterial ulcer, and on the right is a very typical venous ulcer. This is I discussed this in the venous disease section. You talked about this in physical assessment. And if you haven't figured it out by now, it's pretty important for you to know the difference between venous disease, arterial disease, what the signs and symptoms are, and what the difference in the treatment is. This illustration comes from your book, and it just diagrams out all of the major arteries and the major veins of the lower extremity. I certainly don't expect you to memorize this. It's just good for you to know what the general lay of the land looks like, and also important to remember that arteries, veins, lymphatic vessels, and nerves all travel in a bundle. They all travel along the same lines. Peripheral arterial disease is also known as arterial insufficiency. Atherosclerosis is the leading cause of occlusive arterial disease. And it's a chronic, progressive narrowing of your arteries, leading to either obstruction or occlusion. You can have organic disease, which is caused by structural changes in the vessel, which is mostly what we'll be talking about. This is what you see in coronary artery disease, and it comes from plaque formation and inflammation. You can also have what they call functional changes, which are short-term localized spasms, and this is what you see in Raynaud's disease. So it's a short-term thing as opposed to organic disease, which is long-term permanent change. Now, your body does have compensatory mechanisms such as peripheral vasodilation, anaerobic metabolism, and these are not meant for ongoing needs. Your body also can develop collateral circulation, both in the heart muscle and in your skeletal muscles, and you can get the growth of vessels that grow around the occlusion to help supplement the oxygenation to those tissues. However, this takes time. It takes a lot of time, and it takes a bit of intention on the part of the person to exercise those muscles in order to develop that collateral circulation. This chronic progressive narrowing of the arteries produces ischemia, ulceration, and can eventually lead to necrosis and amputation of the extremity. The symptoms of arterial insufficiency usually appear late in the course of the disease. They appear when the diminished blood flow to a particular muscle in an extremity produces changes in that extremity, and it's quite often based on activity, or you can see it in wound healing as well. So what you get in terms of activity symptoms is you get claudication. Claudication is a cramping pain in the calves, and it's associated with activity or exercise in the beginning, and then later in the disease you get pain at rest. What happens is the blood supply is decreased, and you can't, or it can't keep up with the demands from activity, which creates ischemia. Sometimes they'll call this intermittent claudication because it occurs intermittently with exercise and then goes away with rest until, of course, later in the disease. Compare this to angina, which you'll have what they call chronic stable or exertional angina, which only happens with exertion, and then you'll get unstable angina, which is pain at rest. You get skin and nail changes. So the skin color changes are associated with the blood flow. It's pale when elevated, because you're talking about arterial blood flow here, not venous blood flow here. Remember, when you elevate venous diseased extremities, that gets rid of that pooled blood there and helps it get back into the circulation. When you elevate arterial diseased extremities, it's harder for blood to get down to the extremities, and so they're pale. When they're dependent, they get this reddish purple, sometimes they call it a rubrous color, or sometimes even a cyanotic color. You get hair loss. You can get very shiny legs, skin with no hair. The nails are dry, flaky, thick, and your pulses can be very diminished. If they're absent, that's really an issue. And so before you say you have absent pulses, make sure you know what you're talking about. Get out the Doppler and see whether indeed you can determine any blood flow. The arterial ulcers have a very characteristic shape, and they're located in characteristic places on the body. They have a very smooth, round shape, that kind of rolled edge, the pale base. They're painful. They're very difficult to heal. They often develop cellulitis infections, can become gangrenous, and you can also result with an amputation. The toes, feet, the bony prominences on your malleolus and your heel, these are very frequent places that you'll get an arterial ulcer. And one thing they talk about with arterial disease that you can kind of remember if you like mnemonics is the 6 Ps. So pain, pulselessness, uh, I can never say that, but that basically means coldness, pallor, paresthesia, and paralysis. Those are the 6 Ps, and if you want a memory aid, that might be able to help you. This slide is from the lay literature. It's from a website meant for people to learn more about peripheral arterial disease. And it outlines visually the signs and symptoms that they might want to look at. Pain that makes it hard to walk, pains that they can't either walk far, or wounds that won't heal, and then what to do if you have it. You need to go in and get checked out, and what you can do to prevent it. Of course, smoking, controlling your blood pressure, exercise, and then also seeing your provider. So this is just basically in pictures what I just talked about. We need to always keep in mind normal age-related changes. So hair loss is a normal occurrence with aging, as is thickening of the fingernails and toenails. So if you look at the extremities of older adults, these signs alone are not reliable indicators of vascular problems. So you need to look at things like pulse characteristics and symptoms of pain or claudication, color of the skin, when the legs are elevated versus when they're dependent, edema, presence or absence, and also the skin temperature. Those kinds of things all have to be considered with older adults. So one of the diagnostic tools they will use in peripheral arterial disease is the ankle brachial index. A normal ankle brachial index is 1. That means that the systolic blood pressure is the same in the ankle as it is in the brachial artery. They will also use ultrasound as well, and there's a technician that measures the blood pressure in the ankle and the arm, just like it shows here in the picture, and then they get an idea of the differentiation between the blood flow in the arm and the leg, and that gives them an indication of how severely compromised the flow is due to the arterial disease in the legs. Besides diminished flow to the extremity, one of the dangers of peripheral arterial disease is arterial thrombus and embolus. Arterial occlusions are often very sudden and dramatic. A thrombus, which is a stationary clot, forms from an injury to the vessel wall, or it can form from sluggish flow that occurs around plaque formation. It can come from polycythemia when there's too many cells and they clump together. Dehydration can be a contributing factor, and also if you do repeated arterial needle sticks, like a whole bunch of repeated blood gases, that can also cause an arterial thrombus. The thing about the embolus then is it breaks off from the thrombus and lodges in an artery that is too small for it to be able to pass, and that causes an acute arterial occlusion. There are other causes of emboli, and those include dysrhythmias such as atrial fibrillation, prosthetic heart valves, where cells can be broken up or adhere to the heart valves that don't have that protective endothelium that your normal valves do. Myocardial infarctions, also rheumatic heart disease, mitral valve disease, all of those things can cause emboli. The onset is abrupt because you've got abrupt cessation of arterial flow. And it depends, of course, the onset and the symptoms depend on the location and the chronicity of the peripheral arterial disease. So the signs and symptoms in the extremity that you might be looking at are, of course, those 6 Ps that we just talked about: pain, pulselessness, coldness, pallor, paresthesia, and paralysis. So any of those things that happen suddenly, especially the pulselessness, suspect an embolization. That is blocking the blood flow. Treatment, of course, needs to be initiated immediately because ischemia can progress to necrosis rapidly. And treatment includes IV anticoagulation, heparin, fibrinolysis, which is giving them a drug to lyse or break up the clot, and then sometimes they will actually surgically remove it in an embolectomy. Treatment for arterial occlusive disease includes exercise. Walking vigorously for 20 minutes a day encourages the growth of collateral circulation and reduces the severity of the claudication in the majority of patients. Now, this is started slowly, very slowly, and you work up to a faster pace, eventually getting up to that full 20 minutes of exercise. The goal here, of course, is to increase that collateral circulation. The same thing can apply for if you're talking about arterial disease in the coronary arteries, that exercising vigorously 20 minutes twice a day can help grow collateral circulation in the heart muscle as well. So then there are medications. Now the goal with the medications is to increase the blood flow through the peripheral arteries, to decrease the risk of clot formation in the blood vessels, and to control lipids, which is the problem in the first place. That's what's causing the plaque. So you think about antiplatelet agents and platelet inhibitors. These can be used alone or in combination with other drugs. Aspirin is the most commonly used antiplatelet agent, preventing the aggregation of platelets in the arteries, but they can also use platelet inhibitors such as clopidogrel, which you may also know as Plavix. That can be prescribed, and these drugs increase blood flow by inhibiting clot formation in the vessel. So they don't do anything for the flow or the vessel diameter or anything like that, but they inhibit the clot formation, which then allows the blood to flow freely. Patients who experience acute ischemia may receive thrombolytic therapy, as we talked about a little bit ago. Something like TPA, Altpace, for instance, is one drug of choice that they use for thrombolysis. There are also cholesterol-lowering drugs like the statins. An example of that would be atorvastatin. This has been shown to be effective by decreasing the low-density lipoproteins, the LDLs, and increasing the high-density lipoproteins, the HDLs. Remember, the LDLs are the bad cholesterol, the HDLs are the good cholesterol. And this reduces plaque deposits in the arteries and therefore lets the blood flow more freely. There are also invasive treatments. They can do a percutaneous transluminal angioplasty, which is sort of like the same thing they do in the cardiac cath with your coronary arteries, only they'll do it in the leg. They also can do a laser angioplasty, same thing, only using laser. And then finally, they can do surgery. They can do a bypass graft, just like they would do in your coronary arteries. So this is a picture of a fempop bypass graft, which is when they are taking a vein and bypassing uh, the, the area that is diseased and in a sense revascularizing the area. It shows it high up a little bit, and then it shows it down a little lower because it looks like the diseased spot in um, diagram B is a whole lot longer. So anyway, this diagram is from your book. And surgery, of course, would be a last resort if the medical therapies had not worked. Nursing management is very important in peripheral arterial disease, and the diagnoses that you would be working with are acute pain, ineffective tissue perfusion, activity intolerance, and knowledge deficit. Things that you're looking at here are trying to help them maintain the arterial blood flow to the lower extremities. Your interventions would hopefully help protect the tissues from further injury from either pressure on them or from further constriction of the blood flow. If they have wounds, you really want to try to prevent any kind of possible wound infection. And then also there's education for lifestyle changes and self-care. One thing that people don't think about is the clothes they wear, especially the kinds of socks and shoes they wear. And that's a big thing that you can do to help educate them in terms of the effect of constriction and pressure and what effect that has on their skin and on the limited arterial blood flow that they already have. Of course, there is exercise, and as we just discussed, exercise encourages the growth of collateral circulation, and so help with an exercise program is very important, and people need a lot of support for this because it's very slow going to increase the progression of the exercise, and it's also painful because we're asking them to exercise to the point of pain. Older adult considerations may be the things we talked about, how it's a little hard to assess given normal age-related changes. Also, they don't have really good vision or perhaps good mobility, and they're not able to see as well to take care of their feet. So they may need some help with that. And then, of course, smoking cessation is always important when we talk about any cardiovascular disease, but it's particularly important in arterial disease. How are you going to know that your nursing care is working? Well, are you seeing changes in their peripheral pulses? Maybe they're becoming a little stronger. Is their skin intact? Are you seeing improvement in those vascular ulcers, or are they extending and becoming worse? Are you seeing changes in their skin, in the color, the sensation, and the temperature of the skin in the lower extremities? How about the patient's perception of pain? Are they able to walk a little bit farther without pain these days? Do you see that they're adhering to the changes that you're trying to make in terms of diet and medication, smoking cessation, and activity? And then also, how are they tolerating the exercise activities? Are they able to progress with them, go a little farther, or is this becoming a barrier for them? These are some pictures of arterial ulcers, and I'm not going to go into a lot of this because when we get to the skin section next quarter, we will talk a lot about arterial ulcers and their treatment. The one thing I want you to notice is that the eschar at the base of the ulcer is left in place until it's debrided by the provider. That's not something that we poke around on. And then also, we always make sure that we use moist dressings on clean wound beds. If you keep that granulation tissue moist, it will continue to grow and heal. This picture's from your book, and this is something that we definitely don't want to happen. This is gangrene of the toes, it's progression of arterial ulcers, infection, and finally tissue death, and these feet are going to have to be amputated, I'm sure. These are hands that both have Raynaud's disease. If you recall, Raynaud's disease is a spastic occlusion of arterial flow. It can often happen when a person is stressed or cold, and usually what you'll see is that the hands, the portions that are affected, the fingers, will become very white and very cold and very painful. If this occurs over a long period of time, you can develop arterial ulcers and gangrene, as is shown in the picture on the right. The major nursing intervention for Raynaud's disease is teaching the patient to protect the extremities and to prevent injury. They need to be taught to dress warmly when in cold environments, and really even when you wouldn't think it would be terribly cold. For instance, in the spring and in the fall, when it's just a little cool, people with Raynaud's often suffer because their hands get cold. So wearing a hat and gloves especially, is important. Layering is very, very important for these people. Warm socks to protect their feet, and wearing protective gloves when reaching into warm and cold places is very important. Teaching them to avoid cold temperatures when possible, and to manage stress is important. And as always, tobacco use has to be stopped. Absolutely has to be stopped. If they can limit caffeine intake, that's good, because caffeine is a vasoactive substance. If appropriate, of course, as a smoking cessation program, along with the teaching to protect themselves and prevent injury, those things can be the most important and valuable things you can do as a nurse to help these people. An aneurysm is the bulging, ballooning, or dilation at a weakened part of the artery, and this actually decreases the diameter of the artery. Uh, the cause is unknown, but really anything that weakens an artery or causes the loss of elasticity of arteries can cause an aneurysm. So if you think about it, risk factors would be atherosclerosis, hypertension, smoking, uh, any kind of trauma, and then of course any congenital anomalies that exist. Um, Interestingly enough, Medicare will allow a one-time screening for somebody over the age of 65 with a smoking history. And age is important, but that smoking history is a big deal. And these are usually silent. Unless they're picked up incidentally for another reason, they can be silent until they burst. It can affect any artery, but the most common artery affected is your abdominal aorta, and they call that a AAA, an abdominal aortic aneurysm. And as it says on the slide, if they're small, less than 4 centimeters, they're usually silent. And sometimes when they'll do an abdominal exam, that's why you look for those pulsations or masses when you're doing that depalpation or the inspection on an abdominal exam. The treatment is surgery, and they do an endovascular stent or a balloon, or sometimes they'll graft the stent with a endoscopically, or sometimes they'll do a conventional open repair. It just depends on the size of the aneurysm and the person. Survival of a AAA increases with elective repair. If it bursts and it's emergent repair, the survival rate is much less. So when you find out someone has one and it hasn't ruptured, the focus then is to treat them by lowering the blood pressure and treating the pain. And the pain is sometimes the first and only symptom you'll have. So following up on that business about the pain, back pain or flank pain is usually the first symptom. And if you think about it, that's sometimes the same symptom that you'll get with a kidney stone or with pyelonephritis. And so that doesn't necessarily make you think, I have an aneurysm. You maybe get a feeling of abdominal fullness. Sometimes there's nausea. If it's big enough, you can see a pulsating mass in the abdomen. And if it ruptures, it is severe, sudden back pain. Diagnostic tests they do to look for aneurysms, an ultrasound, a CT, and sometimes they'll do an aortography. So therapeutically, of course, if you can take a wait and see approach. If the person is either not a candidate for surgery or maybe the aneurysm isn't big enough that you want to risk surgery. So they will observe for growth in the aneurysm. They'll maintain blood pressure. And then eventually, if it either gets big enough or looks like it might dissect or whatever, surgical repair, and then of course a graft. The complications of an aneurysm are clearly dissection, and then you have rupture, shock, hemorrhage, and all too often death. So the priority nursing diagnosis here, of course, would be acute pain, then risk for deficient fluid volume if indeed you do have hemorrhage, and then risk for ineffective tissue perfusion, again, if you do have the rupture and the hemorrhage. So if you're monitoring and caring for someone who has an aneurysm, the expected outcomes, of course, would be that they wouldn't experience that rupture or dissection of the aneurysm, that they wouldn't have pain, and that they would understand management of the medical condition. And a lot of that has to do with patient teaching them how to monitor and treat their blood pressure monitor their cardiac function, manage the pain, and really managing their lifestyle. They want to avoid physical stress on their abdomen. They want to avoid lifting, the pushing, pulling that gives you that intra-abdominal pressure and puts stress on that aneurysm. Evaluation would consist of evaluating their understanding of the teaching related to the disease process. Are they making their follow-up appointments? Are they taking their meds? Are they doing the recommended lifestyle changes? Those sorts of things.